I'm going to talk today about depression, why we don't understand it, and how we can improve our understanding of depression as a disease from different points of view, which I believe you can use in your future reasoning about some ethical issues in relation to depression. I'm Milena Čukić, and I'm basically engineer of biomedical electronics turned neuroscience with PhD in electromagnetic stimulation of the brain. First of all, what is depression? I'm not going to succeed in giving you all the physiological, medical, psychiatric, engineering data in such a short time, but my intention is to ask some intriguing questions to give you different sets of insights and results of the research and some facts. So, since you're dealing with philosophy, there is one deeply rooted error in today's reasoning in medicine, which is belonging to Descartes. That strong and sharp split between body and mind has utter consequence of how we perceive depression. And I will show you why I think this is one of the causes for our misinterpretation and misunderstanding, giving you some practical reasons, some insights from my own research, and first of all, I will try to mention as much as I could in this talk about the research of other significant people in my scientific life. So, first of all, what is depression? It is classified as a mental disorder, one of psychiatric illnesses, which can be pretty severe, and it is classified according to so-called DSM-5, which is manual which psychiatrists are using clinically to make decision whether a person is clinically depressed or it is about the severity of disease. So depression falls in the group of mood disorders. What does that mean, mood disorder? Basically, it boils down to inability of people who are depressed to control their feelings, express their feelings, actually to control their affect. And I'm going to try to give you some physiological explanation or neuroimaging explanation why it is so. But first, let us see the clinical picture. Someone who is depressed usually feels the sadness most of the time during the last few weeks or so. Then depressed person has problem sleeping. It is not insomnia, but this is the consequence of them thinking all the time, ruminating about negative thoughts, and they're really bad in stopping their negative thoughts. It is not to say that this is something bad in their personality, but this is one of the symptoms that depressed person have negative thoughts, actually like a kind of aggression towards self. You're, gloating about yourself being incapable, ineffective, etc., etc. So this is one of the symptoms. Then in the night, they actually cannot switch off that inner critic saying that you're not good for anything, you don't deserve to live, etc., etc. So the next thing is that people suffering from depression has also very rare thing. I didn't hear that for any other sort of disease. They become incapable of enjoying anything in life, even the things they enjoyed before. So this is a very important symptom. For example, someone who is a gardener cannot even enjoy the smell of the roses. Or someone who likes cooking and eating, who is gastronomic fun, he cannot enjoy in eating anymore, in food and all that kind of pleasures. People usually lose interest for sex. Their sex drive can be really low. And among other symptoms, they have different kind of, how should I say, pains in different kind of bodies which are not traceable. Actually, when you examine them, it turns out to be, you cannot detect anything physiological. But one of the most important things in the whole that clinical picture is that person feels somehow so out of the world, needs to seclude herself. They become socially excluded. They stop seeing friends frequently. They don't talk too much. They actually shut down. And some people even think that this is a kind of natural reaction if other people are rejecting you, etc., etc. But about that later. Most important feature of depression is so-called anhedonia. Anhedonia means that you cannot enjoy previously enjoyable things. From playing football to food, sex, music, whatever used to be significant to you and actually gives you the zest of life before. And there are basically two phases of disease. One is called episode, when person really feels bad and would rather not get out of the bed because the whole world is terrible, there is no point of living, there is no point of doing anything. And in that phase, people suffering from depression, especially from very serious depression, if you say zware depressie, they actually have something which is called tunnel vision. They cannot see the solution. They think this terrible state, when life is so terrible and unbearable, will last forever. And the role of the therapist who is working with that person, if it is, let's say, clinical psychologist or psychiatrist or any kind of therapist working with a person, their main role would be to help person get out of there and go to the safe side. Because one of the symptoms of depression can be suicide ideation, meaning that depression is the only mental one of the rare conditions that people are thinking about ending it all. And I'm not going to go in depth, I will mention suicide later, but think about this. People thinking like that, feeling that low, have also a kind of cognitive decline. It is temporary when they're in episode. They cannot think straight. They are focusing only on negative things and they cannot have bigger picture of, let's say, a problem. So I'm emphasizing this because you're going to need this later when you, let's say, think about autonomy of the person. If you give that person who is in episode, who has cognitive problems, whose memory is not working, whose attention span is declined, etc., etc., etc. If you treat them like a healthy person who is capable of arriving to a reasonable decision, like ending the life, you're making a big mistake, because all that movement with giving people suffering from depression opportunity to ask ending of life is fundamentally wrong. Because I have to remind you that every functioning MD, being a psychiatrist, of house arts, of anyone who is working in medical care, falls in the group of people who must obey Hippocrates' oath. And their first commandment is not to do any harm to the patient. So for me, it's inconceivable that it's expected from a doctor, especially when a person suffering from depression is in question, to actually help them take their life away. This is a huge ethical problem for me. I will give you now some of the data which I gathered in the last 7 to 10 years when I started working myself on detection of depression and studying all kind of literature coming of various avenues of research. But now let's look at the data. For example, I'm giving you data now which were valid before the onset of the pandemic. I think they're pretty worse now. For example, due to the fact that every house artist can prescribe you antidepressant medication if you say that you're depressed without the consult with psychiatrists, because waiting lists were between 6 and 9 months before pandemic onset and now are much longer, I suppose. Based on that fact that every family doctor can prescribe them medication, we had the data from 2019 that 1.5 million people in Netherlands were daily taking antidepressants. Knowing that many people who have those kind of issues are afraid to report that and seek help. Sometimes researchers are mentioning even that probably 50% of people are not reporting the illness until it becomes so serious that they must seek help. Only a fraction of them are taking antidepressants. What are antidepressants? Antidepressants are drugs which are invented back in 50s, and since 50s not a single novel drug entered psychiatry. It is based on monoamine theory, stating that certain chemicals in the brain called neurotransmitters, you probably heard about dopamine and serotonin, which have certain normal amounts in healthy person, are different in depression, meaning that depressed people are lacking those chemicals in their brain. So the antidepressant drug is helping to put back on the normal level of those chemicals in your brain. But recently published study, actually it's not recently, it is in 2017, it is a so-called STAR-D project, which was a multicentric study comprising of more than 8,000 people suffering from depression, came to the conclusion that the overall effectivity of antidepressant treatment with antidepressant drugs is only between 12 and 30%. 12 and 30% is really low effectivity, and they were measuring the effectivity during the first year of the therapy. Let me tell you what is wrong with that. First of all, antidepressant drugs usually have severe side effects. This is not to say that people intentionally start that kind of medication knowing that, of course not. But let us go a step back and see how any medication entering the market is actually checked. For example, you want to market a certain drug. After producing, you have to run clinical trials and you have to report to the authorities what the effectivity was. So if you're applying, let's say, for FDA, Food and Drug Administration body in US, the average effectivity has to be higher than 80% or 85%, depends of the certain medication. But those samples which are used for clinical studies are notoriously small. When I say small, it is usually less than 100 people. And every drug which is marketed, and it's on the population, so big number of people are taking those drugs, they're reporting side effects which are not known before. This is general for every single drug. And that means that only in the first 10 years you can have back the results of that huge experiment on the overall population and see what actually the harms are. So the harms are many from antidepressants. One of the most unacceptable is that I heard from the patients that because the targeting dopamine in the brain, they're actually having problems with movement disorders, which they didn't have before. And I heard from psychiatrists, because I work with psychiatrists and I collaborate in bigger projects in several countries, they say, I can even handle depression, but I need to be stable and autonomous in my walking, in my life. I'm not intending to become invalid because I want to get rid of depression. Second, there are statistics saying that some 30% of people who are prescribed antidepressants never appear to pick up the drugs. So, because even if you try and Google what are the side effects, you can easily find that. And people are aware that medication are not perfect solutions, so many people are not prepared to take the drugs all the time. And for example, if you look at the whole picture, how people are treated and what are the procedure, many psychiatrists and many people dealing with the problems of depression, being families of depressed people who are unable to work, unable to live for months, even sometimes years, it is obvious that we need some change. I will return to that a little bit later. So let us focus on some basic facts about the illness. There are several studies, epidemiological studies, and I will pick one which is coming from the Netherlands in NESDA study. Says in conclusions from a couple of years ago that 1 in 4 persons have encountered with depression and anxiety during the whole life. This also is in accordance with highly esteemed Professor Jim van Os, who is trying to innovate and improve how the mental illness is perceived and how it is treated. And that boils down that mental illnesses are not so easily to classify, because every mental illness, especially depression, has many dimensions. And even if you're a very skilled therapist, sometimes you leave some details out. And it is to say that all of us are on the spectrum, because give me one person that you know in your life that didn't have a crisis, any sort of crisis. For example, the onset of depression can be some big life event. For example, a person loses someone very close, a spouse, a parent, a child. This could be the trigger for depression. And there is nothing wrong with that. If you hold someone very dear and close, just disappear from your life, you cannot recover in a couple of days. The process of grief and mourning can last very long in some persons. You cannot just give up the idea about your spouse or someone you spent 20 or 30 or 50 years of life with in a week and be cheerful and normal. This is simply not natural. Things are not going like that. And the normal process of mourning can last a certain amount of time. But there is all kind of mistakes done in the past. For example, in US in 50s, it was considered that mourning lasts more than a year. It should be treated with antidepressants like depression. And it is very individual. You can judge about that knowing many people around you. So medication of normal grief is one of the mistakes in overall picture about depression. Second thing is that they're basically, this is overestimation, but I will say it anyway because it's important for me to understand some dimensions of depression. There are basically 2 subgroups of depressions. One are so-called one-off depression, which can recover after a certain period. For example, somebody loses someone or job, or it is stressful life event, after which person simply feels very low for a certain amount of time, but after one personal amount of time needed to recover, they never have depression again. This is so-called reactive depression. And another depression which is more complicated is endogenous depression. What does that mean? It boils down to the structure of personality, actually. People who have reactive depression are people who are really well connected, who identify with their groups with something bigger than them. For example, it can be a church, whatever congregation they have, their community or their family, or even their company or political party, and they feel secure as a part of something bigger. But this is a certain fashion in how those people are solving their problems. They become a kind of protected from a community or somebody else, and they actually let other people help them. So if they go to the doctor and say, I'm depressed, and get antidepressant drugs works for them pretty well. But if you are a proactive kind of person who is used to solving her problems on her own, doing whatever she can, daring to start something new, very independent person. This is also the thing when you see someone who is very successful, someone who is even wealthy and have a nice house and happy family and is very highly esteemed, you have problem understanding why that person is depressed. Those are people who have really strict internal standards and they failed according to their own terms. And endogenous depression actually has much longer times to recover, and it can repeat during the life because it boils down to the mechanism how those people perceive themselves in the world, how they solve their problems, how they deal with, how should I say, relationship with others. It is very complex, but here we are coming to one misinterpretation, which I'm sure you read somewhere, because what you read in the print very often is get out of the context and it is not interpreted well. For example, you probably heard that stress has some role in depression onset, but it is counterintuitive. People who are in the second group with endogenous depression, they actually doesn't need that much stress to precipitation to get sick. And then we are coming to the issue of diathesis. What is diathesis? Diathesis in psychiatry says that you have some kind of predisposition. Like when I will make comparison which comes to my mind, for example, that you have certain kind of disease in your family and you're considered to have predisposition. For example, if your mother or grandmother has certain kind of cancer, it is probable that you're more likely than average woman to have it. Or if your father had a heart attack or stroke, or your grandfather as a male, you probably have higher risks based on familial history. But in depression, it is not that straightforward, because there was also another one misreading of the results, because a couple of decades ago there was an idea originating from Netherlands also that there is a genetic predisposition for depression, and based on that study, I think millions were invested in that kind of research. It turned out that a huge multicentric cross-section study of all the literature find out that their conclusions were completely wrong. Why? Because it is not one gene which can lead you to a depression later in life. It is a couple of hundreds of genes which in synergy can do something, but this is too general to say that there is very straightforward genetic precondition for depression. But something like predisposition based on your personality traits and the fashion on how you react, how you control your affect, your feelings, your negative feelings, this is another thing. Let me switch to some of physiological findings. Previously in psychiatry, there were clinical entity called melancholia. You probably heard about that. Melancholia actually corresponds with very hard depression, where patients cannot recover by usual therapy. They really hard to treat patients. They usually have endogenous depression, and they usually have something which we call the recurrent depression. Recurrence means when a certain system revisits the states it revisited before, meaning that a person periodically have the same disease. Those intervals are personal, and the thing is that after every episode, I think the statistics are that after the third or fourth episode, person don't even need a trigger. They just wake up one day and they're depressed. Meaning that this is a kind of chronic disease which goes on and off all the life in person's experience. And this is also overlapping with so-called treatment-resistant depression, which is most problematic to treat. So, melancholia used to be an entity in psychiatry, but it is erased, and in current DSM-5, which is current standard manual for setting up the diagnosis and making clinical decisions, which is currently in use, doesn't mention melancholia. And also endogenous depression is not entitled there either. So there is a movement among his psychiatrists, experienced psychiatrists, to return back those entities in DSM and in current clinical practice, because there is a need for that. I will explain why. One of the biggest crusaders for a return of electrocomposite therapy and dexamethasone suppression tests is Professor Max Fink. He also wrote a beautiful book about that called Endocrina Psychiatry. Actually, the title is The Riddle of Melancholia, Endocrine Psychiatry. And he is explaining in that book the history of our understanding of really serious depression, melancholy. And he is mentioning some cases from his long clinical practice, and he's working also with a group of other psychiatrists who share their feeling that current practice is not okay. And for example, he has a patient, female and middle-aged, who tried to commit suicide, and she's obviously melancholically depressed, and she's in clinic observed very frequently with the staff every 10 minutes, every 15 minutes, and they keep a close eye on her and giving her tranquilizers and medications, but taking care of, protecting her to do something dangerous. But then the family actually thinks that they're stigmatized because a member of a family is sick, and they want her to go out of the hospital and be for the weekend with them again. And she commits suicide during the weekend. So the thing is that there is also another environmental reason why people might get depressed. And there are so many factors we have to take in account. For example, in psychiatry, you can hear that they say that if you have some problems in the family, usually the most healthy person got depression, because they're reacting, they're trying to have help, and you can read that something is deeply wrong in those relationships. But this is completely another topic. So I wanted to draw attention to Dr. Fink, who actually described that distinction between the old items, which are get rid from the current diagnostic manual, and they're actually trying to find out some biological underpinnings of all psychiatric diseases, not all, in particular depression, because we are talking about depression here. And he's also talking about some reluctance to accept novel biomarkers, which I can see now, because people simply like their status quo. They usually don't bother to change something, and this is too important question to leave it to be a status quo. Next, who I want to mention here is Professor Damian Denies, who is head of Association of Psychiatrists in Netherlands. And he mentioned, first of all, that problem with overuse of antidepressants, because every house arts can basically give you antidepressants without the check with experienced professional who specialize in psychiatry. And then there is another issue. I bet you would understand what I'm talking about. For example, there is quite novel issue of so-called confused person. What is confused person? Confused person is someone who is doing something really shameful in a public place, and it can happen to someone who is intoxicated with whatever, from alcohol to some drugs, which you can buy here. And police has authority to put that person and place it on nearby psychiatry clinic for 3 days until they gather themselves. And Professor Denies, actually this is data from 2019, they calculated in association that only in Amsterdam they're losing something like 49 million euros on so-called confused people, when actually people who desperately need clinical psychiatrist help actually can't access that. And they want to change that because it's really wrong. Another thing is that, for example, if you look in other psychiatric disorders, when we are looking to mental health issues as general, not only depression is one big chunk of it, it's very frequent. But when you look at that, it doesn't depend actually of culture, economic status, etc. Because the percentage of population which has that kind of problem is something like 7-8% in Africa, Australia, US, Europe, wherever you go. There are some countries when you have higher or lower percentage or something, but generally you can see that this is a certain fraction of population who is expected to have problems like that. And the mental health care system should be designed so that fraction of population can access mental health care. This is also something which requires a lot of effort. I mentioned already to you what treatment-resistant depression is. And there are several problems with that, why those people are not getting help. First of all, if you read the publications in psychiatry, first of all, I think one of the reasons for the present state is that scientists who run laboratories and work on animal model are still getting the highest grants, and they're having controlled experiments on animals, and translation of their conclusions is really hard. So that needs to change. Second, people who are doing clinical trials usually omit very hard and complicated patients. I know that from Psychosenet, which is organized by Professor Van Os, and he repeatedly says that people, for example, who have psychosis and things like that are refused GGD help because they are complicated. So what's the problem? If you have very serious disorder, there must be the way how you can enter a system and how you can get help. So this is something that you cannot see in literature, actually. There is another person which I admire very much. This is Bessel van der Kolk. He's originally Dutch, but he's working in US in last 35 years. I think he's a professor in Boston, and he's working with PTSD. Why am I mentioning that? Because it has connection with depression. People who were subject to trauma, especially in formative period early, they usually have depression on top of that post-traumatic stress disorder. And there also the fraction, this is overlap with PTSD and depression symptoms, but he basically showed that antidepressants for those cases actually have the same level as a placebo, even worse. So he also showed that the way how patients are treated is pretty wrong. And he says that once we change our mental health care organization, how we approach patients, and politics, which are dictating how that goes, we would be better off, but nobody knows when that will change. For example, all those veterans who are coming from wars, they usually have some sort of trauma and they usually have depression, and this is really hard to treat. There is one very interesting study by Tokuda et al. From 2019. They were working on similar project like ours. We were applying machine learning to detect depression from some electrophysiological biomarkers, but they actually performed a neuroimaging study, and they found out that there are basically three most important causes which leads to very hard depression. One of them is trauma in childhood. Second is kind of predisposition, the associated to stress, and the third can be some trigger. And you can't save yourself from the triggers. Even the therapy which are offered to people who are suffering from depression are actually teaching them how to handle their emotions, how to handle negative emotions, which is the most important part of their disease, and how become more resilient. This is something it can be learned. Then another group which I value very much, this is a group working in Montreal in Canada. They actually repeated some studies with antidepressants, and they find out that someone who is taking serotonin reuptake drugs, which is one of the class of antidepressants, even have worsened quality of sleep, because that particular drug even disrupt that further and can lead to obstructive sleep apnea, which is a really dangerous condition. There is another link with cardiovascular disease. This is our latest research because we are working to show how often people who are suffering from depression are dying actually of heart. And sometimes I'm really puzzled why brilliant research, which were published about that since 2006 onwards, no one is applying in practice. For example, someone who has depression, their autonomic nervous system is the part of your central nervous system which is not willingly controlled, and among other things it controls the dynamic of your heart. And heart rate variability is a robust biomarker of depression, and it says that it is something that psychiatrists are not looking for, because they know that on the end it can happen that the depressed person has a heart attack or even a stroke, but they are still not connected because they think it is not explored. It is explored heavily, and it can be I was proposing for example to introduce cardiovascular illnesses screening for depression population, because that can save their lives. Next thing I would like to say is about suicide. One of the symptoms of really serious depression is that the person suffers that much that they want to end it all. And I know that here in Amsterdam there is, in Netherlands actually, there is an organization trying to fight against suicides. They have a call center, etc., etc., etc. But the thing is that until we don't change our perception of that disease, the suicides will go on. I will give you just everyday example. If a person meets someone who already has depression or thinks she has depression, they will say, "Oh, but cheer up. You know, life is beautiful. You just have to gather yourself. This is just in your head." And when I hear that, I really become angry, because would you say that to a person who has cancer? Would you? I mean, somebody told you, my aunt or someone has liver cancer or something like that. Would you say, it is just in her head? This is what I said in the first sentence. Descartes' error. Descartes actually is still influencing how people in medicine think about disease and disorders. Disorder, if you think even about that word, order, disorder is completely different of the order. But from my research of complexity in medicine, order is actually not good. Healthy person's healthy organism is not ordered, it's unpredictable, it's adaptable, etc., etc. So I just wanted to mention suicide as one of the problems which is somehow connected to that initiative of ending life. So from one point of view, you're investing money in researchers and people who are trying to give hand to people who are thinking about ending it all and help them and help them to, stay here, to recover, to become more resilient. And from another hand, you out of the blue decide that you're going to offer people who are depressed option that they apply for assisted suicide. Isn't that weird? I think it's immoral, because if you would know anything about how person in depression feels, you wouldn't even think of it. It is good thing that at the moment that committee which is deciding about that request has to consist of 3 doctors, of whom 2 has to be psychiatrists. But again, I think is fundamentally wrong on the first place, because the Hippocrates oath. Now I would turn to some not so traditional approaches to depression, because there is hope. I already spent a lot of time talking to you about antidepressants, which is actually the first response to depression in classical medicine, but there are several other avenues, and I actually published my book to explain more about that, not writing a word about antidepressants. For example, one of the class of things that helps is electromagnetic stimulation of brain. What is electromagnetic stimulation of brain? You know that every cell in our body is actually producing electrical signal, because our cells have to divide from inside and outside, taking a membrane, and on that border you can always measure the difference between potentials of certain ions inside and outside of cell. So when a group of cells, a tissue, is functioning, whatever the function is, they are producing actually electrical signal which you can measure. Those are the voltages. They are a microvolt. This is the millionth part of 1 volt, but again you can amplify that and you can measure that. You can measure electrical signal from your brain. This is electroencephalogram. Electrical signal from your heart, electrocardiogram. Electrical signal from your muscle, this is electromyogram. And electrical signals from your nerves. And if you want to affect that system, you can see about the health of certain system measuring electrophysiological data. So if you want to see whether someone has a risk of heart attack, you actually record the signal of his heart to see whether everything is okay with that system. And if you want to see whether something is wrong with the brain, you record that EEG and you can see, it should be typical like this, something is wrong here. But if you want to affect that signal, you can apply electromagnetic stimulation. What does that mean? It means that you put certain electrical field or magnetic field in nearness of that signal, of that organ, and you basically add certain voltage on already existing voltage. But there is a kind of stigma, there is a kind of misreading due to one film that was very popular in 60s, The Flight Over Cuckoo's Nest, Although the role of the film was revolutionary in understanding the bad conditions in mental health care in US, there are even today patients who refuse electroconvulsive therapy that could help them and save their lives because they are afraid of seeing that scene when Jack Nicholson is actually put electrodes and he has a shock. And it was, this is horrible to watch because he was basically punished for something that he did. And today we have anesthesia, and I can tell you that if psychiatrists recognize that his patient has melancholia, he can try to treat that person for a year with very low productive means of antidepressants, or he can send that person to electroconvulsive therapy, which helps in 80% of those cases, and the person will be better after that. Of course, there are a number of people, fraction of that population, who are not reacting to electroconvulsive therapy, but it saves lives, especially in melancholia. There are also other types of electromagnetic stimulation. Basically, I did my magisterium and my doctorate on transcranial magnetic stimulation, which is painless. It is first invented for diagnostic of certain brain diseases, but now it can be used for treatments of depression. And also the average effectivity is more than 35% of those who are not reacting on drugs. Also, there is transcranial direct stimulation, which can be even done at home. There is a device, this is a very low current, you can hardly feel, this is just a tingling in your skin. You can put the cup with those electrodes and you stimulate yourself every day if you're depressed. Then there is another sort of stimulation. It is called vagus nerve stimulation. Vagus nerve is important nerve which is going out of our cranial spine, and it is very important for our autonomous nervous system. And vagus nerve stimulation can be done even in ear and with electrodes here, but it is still not in wide use. I will just give you one example. Repetitive transcranial magnetic stimulation, which was invented in 1985, got a go from verzekeraars in Holland in 2019, so it can be applied in cases of serious depression, which is, they waited 35 years. Why? I don't know. Another thing I would like to say when we are talking about other approaches to treating depression, one approach I like very much is coming from cognitive therapy. Cognitive therapy turned out to be very useful in many cases of depression. I don't know the ciphers for treatment-resistant depression, but treatment-resistant means that even that therapy doesn't help. But for majority of people who have, depression of lower severity, cognitive therapy showed to be option. Also, there is mindfulness-based cognitive therapy, which helps. And once you learn that, and you put the person in the scan after 8 weeks of practicing, you can see anatomical differences. The brain can change in that time frame, and you can simply practice that every day, because you're basically trying to change the way how you handle your negative thoughts, how you develop more compassion for yourself and kindness to yourself and other people as well. Another thing I would like to mention here is one of my favorite authors. He's a psychiatrist, a professor of psychiatry, Dr. Irvin Yalom. He's actually someone who developed existential psychiatry, and I think the reason that he had so good results with patients who were suffering from final phases of cancer can be translated to depression, because existential approach to therapy, psychotherapy, is something that works even in worst cases of depression. There is another approach which started developed, I think, more than 10 years ago. Now it is very prominent. It is based on importance of microbiome, or our gut structure and influence on brain, and the role of microbiome in mood disorders. And I can direct you to one of the early researchers of connection between microbiome and depression, Professor Julia Racklich from New Zealand, and you can find even her TED talk about that. Basically, the rationale is in your gut, which is very complex system of billions of microorganisms, like all kind of bacteria, fungi, viruses, and all kind of things which are there. You have very complex neural system, and you have the number of neurons in your gut as half of neurons in your brain. So there are even cells in the gut system. This is endoneural system, which are producing dopamine. And 95% of the dopamine is actually produced in your gut, not in your brain. And I wonder why then the antidepressant story about monoamine theory is targeting the brain and not the gut. Because as I told you in the first part of my speak, who is who? Who is the first who is actually triggering? If you're hungry, you feel that you don't feel so well, and then you eat something and then you feel better. But is this chicken and egg? Who started the first? Microbiome, who via endosystem sent the signaling for central station, and central station take an action, or the vice versa. So that avenue of research is very promising, and Julia Racklich actually showed that giving certain micronutrients in certain doses to people who are depressed actually change their microbiome and change their overall health, meaning that they improve in overall quality of life, and the symptoms in their disease is lower. Then I would guess that you would ask, how would I approach someone I know is depressed? Please don't try to give them advices because you're not professional. And I think even your kindness and your presence, sitting with a friend or relative who is depressed and listen to them talking if they want to talk, or simply be with them and practice your compassion and your support in the kindest possible way, can be therapeutic. You don't have to do anything else, but you have to have a certain kind of understanding how devastating the disease is. It is not just in somebody's head. They cannot collect themselves. They just can't pretend that they are better because they're not. And I hope that with all these facts and the links that we are going to provide you after the lecture, you can improve your understanding on depression and your future discussions, including related problems. So to summarize, I think that this topic, depression as the problem number one, when we are talking about capability of functioning of a person, including an ability to work in the condition, not only brings economical burden, because for example, if you look in Netherlands, the treatment of one person who is going once a week to see the therapist on the year level is 65,000 euros, meaning that light treatment for one person actually costs the 1 year's salary, good salary indeed. So it is not only that, but that can serve to make a pressure on those who are policymakers about improving the mental health care. Second thing is, machine learning and artificial intelligence is buzzword. It has to be everywhere. But I really feel mad when I see an article, your robot therapist will see you now. How you can help someone with such a crippling condition, offering him a bot? It is not moral either, because people who are suffering from depression, they need empathy from another human being. They need a hand. They need someone to help them get out of that cave they're in and help them become more resilient and come back to life. You don't need a chatbot or robot. This is stupid. Huh? And another one, think about next time when somebody asks you about ethical issues with allowing someone in zware depressie to actually ask assisted dying, because I think this is not moral either. And think about also ethical problems of research, because, for example, when you see what branch of research is funded the most, if you say that you're cancer research, you will get money for research. If you claim that you're going to study something about heart problems, cardiovascular disease, obesity, etc., you're going to get funded. But if you want to do research about depression, no, you're not going to get funded. So why it is so? Because cancer you can see, depression you cannot. And again, we are returning to Descartes' error. We are returning to that split that mind and body are separate entities. No, it is fundamentally wrong. They are intricately connected in so many levels, and the problem of depression has so many dimensions that we honestly have to admit that we are just scratching the surface with our understanding about the causes, about the suffering, and about the cure. So I think that after all these things that I just mentioned, you're going to read a little bit more about that, become aware of the extent of this problem, and try to apply it in your future work. Thank you.